So one of the ways we wanted to use this was to look at it in developing countries where it was going to be an affordable item. So just in summary then, the rate of acquisition is very high, from 0 to 2, and beyond that it's very much less. About 50% of the world are infected with H. pylori. And this is just some numbers in these countries. And probably in France, I'd say it'd be like us as well, about 30% of adults are infected, but they'd be more likely people older than 50. So they've acquired it in childhood, and presumably it's then, because of our hygiene is better, we're not getting as much in childhood. So this has got a number of different possibilities. We were looking at it as a preventative measure in animal models and a therapeutic. Nobody is very interested in preventative, really. It costs a lot of money to set up the studies, so it's probably better to at least reduce or to eradicate. So we've done experiments in both scenarios. I'm only going to show you the eradication experiments compared to a standard therapy in a mouse model. This is just, again, we wanted to see if we could interest companies to get involved in preventing it in infants and in toddlers. And we got quite a long way with that, but then the company got taken over by somebody else and they stopped it. We know from studies by Thomas some years ago, many years ago really, that antibodies do prevent H. pylori infection. So it's usually IgA in milk, has a titer effect and protects. The higher the titer, the longer you'll be protected from H. pylori. Hence the idea that breastfed infants will be protected. However, that's not hard and fast, and breastfeeding in our country only about I suppose 20 to 30% will keep breastfeeding up to 9 months, and many don't breastfeed at all. This is just one of the early studies we did where we looked at colonisation percentage, and it's significantly different between control and the hyperimmune bovine colostrum in a mouse model infected with Sydney strain 1 Helicobacter pylori. So it certainly inhibits colonisation fairly effectively. So these were just the outcomes we were aiming for at that point in time. And unfortunately, Helicobacter pylori is one of those scenarios that it's much later in life that you tend to get the problems, gastric cancer or duodenal ulcer or peptic ulcer. In childhood, whilst there's some data that says it induces growth restriction, it's still a little up in the air. Iron deficiency is another scenario of that. But if we can eradicate it or prevent it, or at least suppress it, we'll almost certainly diminish the incidence of diseases in later life. So that's the sort of thing we're doing. Same kind of paradigm, proof of concept. But what we did next was we added N-acetylcysteine, which is both a mucolytic agent and an antioxidant, and it stimulates GSH production by the actual mucosa. And we added in the only antibiotic that so far hasn't induced antibiotic resistance, amoxicillin. And we've patented that, and in some scenarios we looked at that with some oligosaccharides, because the oligosaccharides we showed independently to reduce inflammation in a mouse model of Helicobacter pylori. So, intrauterine growth restriction, there's been some data, but it's fairly small and it's epidemiological, suggesting that people with H. pylori will have stunted children. This is the time you're most susceptible to infection. gastritis, malabsorption, iron deficiency, maybe B12 and possibly vitamin C, growth retardation. Diarrhea is thought to be linked to it, but it's unclear how. Definitely peptic ulcer disease, 100% for duodenal ulcer, which is what Barry Marshall got his Nobel Prize for. Everybody has a gastritis, and it's a differing level of gastritis. Probably about 1 in 6 will get peptic ulcer disease, but only 1 in 6 will get any disease really. So it's an asymptomatic scenario. So an early detection, one of the major risk factors of both ulcers and gastric cancer is H. pylori. So that's it. We like to find ways of detecting those things, and the breath test, which I'll show you in a minute, is one good way of doing that. I'm sure you're familiar with it. These other ones are just scenarios that have been proposed. So in view of the drug resistance, the side effects and the compliance and the expensive therapy, this treatment failure, and it's continued, this I originally put up in 2005, it's continuing to occur, and that's worldwide. And the second line treatment strategies are quadruple therapy, and they're still inducing antibiotic resistance. The potential mechanism for this is, well, we don't really know what the mechanism is, but the NAC, we believe, allows access of antimicrobials and antibodies to the site of H. pylori infection by affecting the mucus layer and giving a kill synergy, and we've kind of shown that. Colostral components many of them are unknown, but they do reduce gastritis. And the antibodies probably provide a continuous sweeping action. So this was our first study. We did look at a range of other things like lactoferrin by themselves, with other things, hydrolyzed and non-hydrolyzed, with and without NAC. And we used a very low dose of amoxil, and we got a 74% kill, which, as did lactoferrin, which when it was hydrolyzed with NAC. But this is the triple therapy, and that gave 95% kill. When we changed that dose, just up that dose, and it's not a massive change, we got 100%. So our proof of concept, if you think back to that cone of proof of concept, that proof of concept now has put us into a position where we should go to a clinical trial in this sort of scenario. And we're at that pivotal point now. Just how would we construct a clinical trial without knowing anything about the particular bugs? Because you still have to use some sort of invasive way to get them. We did publish in 2000 the carbon-30 urea breath test versus severity of gastritis, and unfortunately I left off that it's clearly significantly different, each one of them. As you get a higher load, and this is delta over baseline, cut-off point of 5 we use in our test. So anything below 5 there's no bugs, and the gastritis as measured by histology showed a gradation with a higher delta over baseline. So we've got some surrogate measure of gastritis without actually having to go in there. So if you had a higher urea breath test, you've got almost certainly you've got a more florid gastritis, and that means you've got more risk of ulcer disease, you've got more risk of gastric cancer at some point, depending on what your age is. So that's the way that we go about doing them, and that's just to give you an idea of how breath tests can be used in both clinically and in proof of concept studies. The second example is one that we've also patented, which is a sucrose breath test. It's a carbon-13 labelled sucrose, and we devised it for several reasons. One of them is because when you have chemotherapy, your small bowel is probably the most affected. It gets very damaged. But we can't follow it in any other way, so we needed a non-invasive way to follow that, to devise new, what we call anti-mucositis agents. And I'll tell you now, there are none, really, at this point, for the small bowel. Most work is done with the oral cavity, but the small bowel is worse, probably worse affected than the mouth. So this is just that same idea of all the partners you need Harvest Plus Foundation was not into cancer, but they were into looking at nutritional studies and the state of the gut in the developing world of children. Is around about 50% of children, and our Indigenous Aborigines fall into the same scenario, will have gut damage. So we joined up with Harvest Plus Foundation, got funding from the Gates Foundation as well, within the Harvest Plus to do that. And these are just anti-cancer agents because they would fund our work on supportive cancer care or chemotherapy. And these are just some of the companies that also were very involved in this process because they wanted to look at some of their agents, both of these did, as anti-mucositis agents using this test. There was no objective index of small intestinal health other than permeability, which we do as well, but that's much harder to do and it's quite invasive. So we needed to develop an index to improve the clinical management in chemotherapy, to using clinical trials of putative therapy for gut damage, whether it be mucositis, celiac disease, Crohn's disease, or in enteropathy, tropical enteropathy. So this really is a black box, the small bowel, and possibly the proximal large bowel, in terms of functionality. Even in terms of the microbiome, there's often quite a large distal small bowel bacterial overgrowth, which may or may not affect us. We really haven't got good ways of sampling that or good ways of detecting it, except for a breath test, but it's still non-specific. Okay, this is just some of the other tests that we've developed. I'll go through this quickly. Octanoate for gastric emptying, sucrose permeability in the urine. Small intestinal, we've developed the carbon-13 sucrose breath test. Lactulose rhamnose for permeability. Lactose ureide for motility studies. Marker dyes are also used, but they're not very good. And lactulose. Ethane pentane for inflammation and calprotectin in the faeces for inflamed gut. We just don't know exactly where. So we've developed this as well, and we'll go on to look at other volatiles in the breath in concert with damage to the small bowel and the stomach and the large bowel with some newer tests we're going to put into place. Okay, it's a very simple concept. The carbon-13 sucrose breath test is a surrogate marker of the health of the intestinal villus, the absorptive compartment. Enriched carbon-13 sucrose impacts onto the cells, the epithelial cells, the sucrase, which will be determined by the maturity and the health of the small intestinal villus, is broken down to its constituent glucose and fructose, and it goes to the liver, to the lung, and we collect it at intervals and look at an area under a curve or a slope to determine the health of the small intestine. Nobody's really done that before in any substantive way. So this can now be used to relate to omics of various kinds. We're in the process of looking at relating metabolomics, the microbiome changes, because if you've got a damaged small bowel, what reaches your large bowel will be quite different. So your bugs will have different fuels than they normally would see. We can do it in preemie babies on respirators. We can do it in just children who can't blow into a tube. We can blow into these vacutainers, and this can be done. We've done this in Mexico, remote parts of Mexico, remote parts of Bangladesh, parts of India, remote parts of Australia, and we've sent it to the US as well, and they just send them back. Because it looks like there's nothing in there, we don't have to do anything but just send it and send it back. Sorry, I didn't mean that. That's not true. We do get accreditation. We do say what the sample is. These samples can be, and it's got carbon-13 CO2 in it, and other vials we'll use for volatiles. They can be stored at any temperature, essentially, well, reasonable temperature, for a year, and they're stable, at least a year. We also do it in animals, so we can gavage an animal.